Oh, hi, good evening. Thank you very much for joining this exciting webinar on advancing treatment strategies, managing upper GI diseases with an innovative advanced platform. Uh, as you will learn today, this is a Creo Medical innovative surgical platform delivers a super high frequency microwave and advanced bipolar radio frequency through a single accessory port. And this technology makes it possible to conduct endoscopic surgery by enabling miniature endoscopic device to cut out, coagulate, and ablate with intuitive precision. And I'm glad to announce that we have an exciting lineup of experts with vast experience in advanced endoscopy, such as ESD and third space endoscopy. They will be delighted to share their experience with managing upper GI diseases with this innovative advanced energy platform. Let me introduce the first speaker that we have is Dr. Eduardo Albanese, and he's from Pamplona, Spain. Dr. Albanese, who works in the endoscopy unit of gastroenterology Hospital University of de Navarra, and leads the digestive endoscopy research. And he also coordinated Spanish EMR and EST registry on the national platform and introduced the technique of third space endoscopy in Spain for the first time and published widely. I will invite him to give a talk on navigating esophageal diverticula, a comprehensive strategies for diagnosis, treatment, and long-term management. Over to you, Dr. Albanese.
Thank you, Professor Isaac, for this kind introduction. Thank you to Creo Medical for inviting me to this webinar with this such high respected and high technical skill colleagues. So my talk today is about esophageal diverticula. I will start with because I am the first one in the webinar, so I want to show you some slides that the company lent me just to show this amazing technology. To me, the most important part is the platform. The platform is able to deliver bipolar radiofrequency for cutting and super high frequency microwave for coagulation. This is possible thanks to this device. The device is called a Speedboat Inject. Now we have the slim version, 3.2 millimeters of diameter of the shaft of the device, because the tip of the device is only 2 millimeters wide, and the active part of this knife is 4.6 millimeter length. So you can use the tip of the device, the convex part, and we have to be aware that the energy is delivered in the edges of the device. So you have to angulate the device a little and to control the tip to manage nice control and nice coagulation. We will see in real life videos. With this device, you can navigate over the muscle, so you can skip the vessels in the middle of the submucosa, and you can go and cutting and coagulating the main vessels of the muscle bed from to the submucosa. So we have safety and stability at the same time. And also the platform interacts with the tissue a lot of times, more than 1,000 times per second, automatically detecting the impedance of the tissue and delivering the correct level of energy. So, for example, for the people that we are doing points, sometimes when you are cutting the muscle and you have a zip effect, the device stop cutting. So it's something that we can see on real life when you pass from one layer to another layer. Okay. So let's see how it works, the radio frequency, how it works the microwave. The radio frequency increase the temperature really quick, and it goes to more than 200 degrees. But the microwave increase the temperature in doing a low rise of temperature, and it doesn't rise less than 200 degrees. So this is the reason that this kind of device is so safe to coagulate comparing with other graspers. This is the ability that we like too much. So the cutting is very nice, and the coagulation is very safe. We will see. So going for my talk, I will talk first of all about Zenker femoral endoscopic myotomy, compared with flexible or rigid myotomy. This is a study. There are not a study comparison the three techniques. The technical success with set point, flexible, and rigid is quite similar for set point and flexible septotomy, but for rigid, the clinical success is a little less, maybe around 90%. Set point, depending of the work, is over 90% or near 100%. But the secondary effects with the standard septotomy, with a rigid septotomy, could be as higher as 30%, for example, in this study. From my point of view, the secondary effects, the adverse events in this study are too high for all the techniques, but this is what it is. This is a study. So this is another study comparing set point with flexible endoscopy septotomy. The clinical success in set point was 100%, and from traditional approach, 86%. This is a Zenker, everybody knows. So in a set point, you do a small mucosotomy. So you enter in the submucosal space, you expose the cricopharyngeal muscle after you cut it through till you reach esophageal normal muscle. And after some groups cut the mucosa and other groups don't cut the mucosa. I personally cut the mucosa to flatten the pouch, the remaining pouch, and after you apply clips. So I will show you two videos. In this video, there are two big mistakes. The first one is the patient wasn't intubated. It was a live case in India. We were in a rush. We had too many cases in the same day. I don't know why, but we didn't intubate the patient. And the other is I thought that I was in the top of the septum, but I wasn't. So it's not a real set point. So I exposed the muscle first of all, but I cut it, and I continue cutting. So you see that the active part is the gold part, the upper part of the device, and it cuts very well. So here, it's very rare to have severe bleedings in set point. So we are continuing to cutting. The muscle is thinner, so we are reaching the distal part of the crico, but we continue a little more. And right now we can tunnel in a little, so it's not a real set point, but the technique is the same. And once we reach this thin muscle, it means that we are in the esophageal part. Okay. A very important tip at that time, to me, is to cut the remaining patch, especially in the distal part. Sometimes it's very thick, like here. But if you leave the pouch in place, the patient sometimes doesn't recover very well, and there is symptoms due to this remaining pouch. So I cut the pouch in the middle till I reach the deep part of the pouch. So this way, the recurrence is impossible. So you have cut all the muscle, and you have to have this pouch. After, when you are at the end, you do aspiration. You put a clip in the middle, and after you clip both sides, both edges. Here we didn't have small clips, but I recommend you to use smaller clips with a small stem. So let's go for the next case. It's a similar case. but here with intubation, it was an ulcer due to the food retention. And the technique is to do a small bleb. I don't recommend you to inject too much because you lose space, a small bleb, and better to do it in the esophageal part. It's better to dissect only the esophageal part, not needed to dissect the pouch, the wall near the pouch, because it's very easy to go into the mediastinum. So I do a small hole, even smaller than my cap. I don't have conic caps, but you can use it. But I do a small hole, and once you cut some muscle, it's easier to enter in the submucosal space. So you don't need to open a big mucosotomy. After it's gonna be easier to close it, of course. With the tip of the device and the angulation, you use the active part of the device, and it's really easy to cut. You go fiber by fiber. It's very smooth. And I can tell you here it's very uncommon to have a severe bleeding. I haven't found a very big vessels of arteries in this part of the body. So we are, so we have reached, and this is a thin muscle, so it means that we are in the esophagus. I cut a little more, and that's it. So if you go a little further till the end of the pouch, you are in the esophagus. Okay, so some groups close right now, but I can tell you I cut the mucosa. I recommend you to do this, and it's very easy. Sometimes this is another case with really thick mucosa. Normally, it's not needed to cut the mucosa in the esophageal part because it's too floppy, and it's not needed to cut the proximal part. At that time, you do an aspiration with the endoscope, and you closed. I use clips with a short stem. These clips are they have the ability that if you have failed, you can remove it, grasping the distal part. So this is a very big durability of this kind of clips, and you can pass very easily after the treatment. Okay, what about the point? The deep point and the experiences are really there are few evidence in the literature because the series are really small, and they combine mid-esophagus diverticula with epiphrenic diverticula, and there are few series. Okay, so one of the problems is some groups treat only the motor disorder, because normally this kind of diverticula are associated to motor disorders, but some cases are not associated to that. And sometimes it's very difficult to do the high resolution manometry. So sometimes you have to help the manometry guy, your colleague, with the endoscope, and you can pass the proof with a little with the endoscope. You can do the exam previously to the treatment. And after the treatment, the pouch remaining in place. So maybe new ideas are welcome for the future. Okay. This is another treatment. You can see that even after the treatment, the reduction of the diverticula is small, and maybe you don't have compression, but depending on how you put the barium, you can have one image or another one. So I will show you a nice example with a speedboat, and I will show you something. In this case, we had to pass the proof with the endoscope to help a little, because you can harm also with a forceps. You can harm the proof. And here we are cutting the septum. This is crucial because this is the only knife that can protect all the sides of the mucosa. Because even the protective knives, the insulated tip knives, they don't have the ability to protect one side of the device. So only the tip. And here you can pull the mucosa away, and you can go to the middle of the septum. So this is something that that we can do with this device. So I like this device for this indication. It's okay. It's not a common indication in our practice, but you have some cases. So we are pulling away the mucosa, and trying to reach the mid of the septum, because sometimes it's difficult. It's a difficult part to reach and to dissect. And we are dissecting till the muscle disappear, because the septum. Okay, so it's done. This is a combination of cases, so I will stop here. It was a case of type 3 achalasia, and with 3 diverticula. The first one had no septum, but there were two big septum in the other one. So apart from doing the complete myotomy, so something new that we perform in these cases. Sorry, I repeat again. We trap the mucosa with Ovescos, trying to correct the lumen in one procedure. So this is something different, and you can do this in big diverticula. But I have new ideas for the coming future. So I can show you the final result. So I'll show you the final result here. Let me stop the okay. Sorry. Here you can see that we have straightened the lumen and treating the achalasia and the 3 diverticula in the same treatment. Okay. So my conclusions are: the POEM allows you to perform the treatment of the third space endoscopy from A to Z. They cover all the POEM possibilities. Speedbot is a device whose characteristics allow handling any third space procedure. And new endoscopic technical modification, not in the speed, but just for a technical reason, are necessary to treat some large diverticula, because the pouch remain in place. So thank you very much. We belong to a group from our endoscopy society, and we are open to perform any kind of research or collaboration with all of you. So thank you again for the invitation.
Thank you very much, Dr. Albanese. It's a master presentation. And you're really pleased to see that a small pouch, this pharyngeal pouch, the knife works very well. We will take the question in the end. And I think we're moving on to our next speaker. It's a really pleasure to my Professor Emmanuel Coron, who comes from north of France, from Institute of Nantes. And Professor Coron is a physician in gastroenterology, in hepatology, is interventional endoscopist. Through international stays and collaboration, he developed an expertise in novel diagnostic and interventional endoscopic techniques, which are applied to the fields of both translational research using animal models and clinical studies performed in human. And he's going to give us a talk on POEM, Revolutionizing Esophageal Motor Disorder Management, Techniques, Outcomes, and Future Prospects. Professor Coron, over to you.
Thank you very much, Professor Ishak, for the nice introduction. Thank you to Creo Medical for inviting me to this very exciting webinar. So I'm very pleased to share this talk on POEM. These are my conflicts of interest. You will notice I have no conflict of interest with Creo. We bought the system in Geneva and got the training from Creo, but I feel completely free to tell about the device, whether it's good or not. As an introduction, we can say that POEM now is a procedure that is well known for more than 15 years. It was very successively developed and spread in the Western world after initial setting in Japan. Basically, the strategy is the same, but there are a variety of different techniques between different centers and the physicians. And beyond treating patients, I personally think that there are very important secondary benefits to performing POEM, because it's really helping us to understand third space endoscopy, to better work on the pathophysiology of motor disorders. And for our younger physicians, it's a good way to train for complex ESD, STERP procedures, and also to treat the complications, hemorrhage, etc. So basically, the procedure is well standardized. After a mucosal incision, the endoscope is passed through the submucosal space and goes to the cardia, where the muscle is cut. There is a myotomy of the cardia and of the esophageal wall. And after retrieving the endoscope from the tunnel, we close the mucosal incision. All of these steps mean that people need to master esophageal histology, and this is a very good paper by Roberta Mazzelli, showing all the different types of vessels or layers that you can encounter during the procedure. What does speedboat add to the procedure? I want to thank my co-speaker, Dr. Eduardo Albeniz, who provided me this very, very nice example of pre-coagulation of a vessel, preventive coagulation, because it illustrates how precise this bipolar energy, the microwaves, can coagulate the vessels in a very elegant manner. You can almost caress the vessel. This is the mid of the vessel, and you can touch the base of the vessel. I accelerate a little the video. Touch the vein that is entering the muscle with protecting the muscle with the insulated tip. So this is very nice to coagulate this way, very precise. This is now a personal case. I think it was my second case of POEM with speedboat, so it's important to check up the esophagus and clean all the saliva or the food, check where the cardia is, go 8 to 10 centimeters above to perform the mucosal incision. Before this, I like the NBI look to check the IPCL, showing that there is no big inflammation in the mucosa. Perform a big bleb submucosal cushion with the needle of the speedboat, and then we rotate the speedboat to really adapt it to the mucosal cut. I personally like transverse incisions, and after that, it's important, of course, to, so I want to draw your attention to the time also. We started basically 10 minutes after 1 p.m., just to give an idea. Then it's important to do the tunnel, and again, the device allows to perform very precise preventive coagulation of all the vessels. You can recognize the muscle on the right inside and the mucosa on the left inside. And it's important to avoid mucosal injuries to keep the permeability. After doing the tunnel on the whole length of the esophagus, we go back in the lumen to check that there are no mucosal injuries, go back in the tunnel and perform the myotomy. So again, we can rotate the device. Here, the circular layer is cut, and you see it's very effective, very direct cut from the upper part to the lower part of the esophageal muscle. And one important message is that it's important to cut the gastric side of the muscle at least on 2 to 3 centimeters. Here you see the esophagus is split in 2 halves. We go for the gastric muscle, and we do not hesitate to cut it on 2 or 3 centimeters. And we can perform also not preventive, but curative coagulation, curative hemostasis, to avoid one rare complication, but is annoying for the patient, which is an hematoma in the submucosa after the POEM. This happened once in my experience. It is something that needs to delay the food ingestion. And at the end, phase 4 is very important to take care of this, is the mucosal closure. And we use standard clips, but we pay attention to the fact that clips take the whole thickness of the mucosa and the underlying submucosa to completely close the incision. And you see the final clip is put here. This is the timeline. So we took more or less 25 minutes, and which was for an educational video, which means it was a little, did you record? No, I forgot. Okay, I need to do a second pass, etc. So we can easily go down to 15 minutes to perform procedure with a speedboat. Now let's go to the results in the literature. Very few data on speedboat with POEM. Only one paper on 2 patients, approximately the same duration, 30 minutes, 100% technical success. And if we take some altitude and go to the literature on POEM in general, all you need to know is in the ESGE guideline, which is very nicely drawn, very precise. And it's important to have some take-home messages, very simple one. Symptom relief are the primary treatment aim, not images or other secondary stuff, but to treat the patient from the symptoms, that the treatment decision in achalasia should be made on patient's characteristics, patient's preference, which is key, because when you explain surgery or the risk of recurrence after PD, they generally prefer POEM. And after POEM, the guideline recommends follow-up endoscopy 2 to 3 years to make sure there is no Barrett's esophagus or esophagitis. The guideline also gives clear recommendations to use low-flow CO2 insufflation, antibiotics, and the fact that anterior or posterior myotomy can be used without any difference, but that the myotomy has to extend to the gastric side. Why is that? We have 2 important randomized control studies. First one dealing with short, which means 8 centimeter versus long, which means 13 centimeter myotomy, more than 200 patients, Italian study from Roma, with a clinical success that is not different statistically, but the procedure time is of course shorter with shorter myotomies, 40 minutes in mean versus 50 minutes with long myotomies. So go for short myotomies because you will save time and you will be as efficient with no more GERD. Do we need to prefer anterior or posterior approach? Another RCT, which is a multi-center from Amsterdam to Louvain to in Belgium and Roma. Same success rate, no difference in terms of GERD. So you have to decide according to patients' characteristics or expertise, whether you prefer anterior or posterior, doesn't matter in clinical practice. Finally, what are the outcomes? I very subjectively chose this paper because it's our personal experience. We decided to look at the results between naive patients and those that already had pneumatic dilations, Ehlers myotomy, botulinum injection. And what we show is that while the groups were the same, and I draw your attention to the fact that, of course, there's a predominance of type 2 achalasia, but there were also some type 1 and some type 3, which are more difficult to treat. And of course, the fact that people that were not naive to treatment had much longer history of achalasia symptoms than those that were naive. Finally, the clinical success is not statistically different, maybe a little better in naive patients, but still very, very satisfactory in those that were previously treated at the cost of a mild number of severe complications. But this is, of course, important to inform the patient. In our experience, on 100 patients, we had 1 patient that required surgical drainage without esophagectomy, and 1 patient who required radiological drainage. So we have to inform them that it is not completely 100% safe. What are the predictors of complications? This is important in this talk. Of course, if there's a complex anatomy like a sigmoid esophagus, if the physician is less experienced, if we use TT knife, which are more dangerous, and if we use aggressive current, which are associated to a higher rate, and you see the odds ratio, higher rate of complications. This is important to keep in mind. Finally, one last study, very nice randomized control study just published in Gastro. showing that there is a preference to treat patients who failed after LR myotomy by POEM rather than pneumatic dilations. Physicians are always a little anxious about performing POEM after LR myotomy, but it's much better than pneumatic dilation. So no worries, go for it. And as a perspective, I think we need studies. We need more studies. Eduardo Albanese is running a large clinical study on a POEM with speedboat. It will be very interesting. I think it's important to know whether speedboat can lower the damages to tissues. And also, it's always very nice to bring a little hint of intellectual flavor to technical endoscopy. So I think the first space is also a very good way to perform biopsies from the muscle. This is preliminary data from our research group where we send those biopsies to the histologist. The image in the middle shows H&E staining, looking for nerve fibers, fibrosis, inflammatory infiltrate. And the right inside shows a FFOCM, which is a new extemporaneous microscopy device looking for mesenteric ganglia, inflammation, etc. So I think we need to optimize what we get from the procedure to extend our knowledge on the pathophysiology. So finally, ladies and gentlemen, the chairman, POEM is safe and effective in the treatment of achalasia. I personally think that it should be discussed for all patients, whether they are naive or previously treated, but that the experience of the center is key. Probably speedboat has the potential to offer less tissue damage than the other devices with no longer procedures and the very safe way to handle it. And that we need to look at more, I think, studies to see how POEM helps progressing in advanced interventional endoscopy, understanding the pathophysiology, and finally looking for precision medicine for chronic motility disorders. So I want to thank all my team, my previous team in Geneva, who helped me to publish this book. It's also in English on all we want to know in POEM. My team in Nantes and the research lab looking at all these microbiopsy parts from the muscle. Thank you very much.
Oh, thank you very much, Professor Caron, and thanks for keeping your time. And it looks like a wonderful book, and congratulations on that. And also, it's a little housekeeping is about, please keep the questions coming, either Q&A or a chat box. I will transfer them to the chat box so all the speakers can see these questions. We'll take questions in the end. Now we're moving on to the sort of last talk, and it's a real pleasure to invite an expert endoscopist and a good friend, Dr. Adolfo Parra-Blanco, who's a consultant gastroenterologist and interventional endoscopist with a wealth of expertise. Having trained in Japan for 4 years and worked in hospitals in Spain, Chile, and now in UK, Dr. Parra-Blanco has worked under a variety of healthcare models and contributed more than 100 clinical publications during his career, and covering different topics of early GI neoplasia and endoscopy, including some developments to make EST more safer and applicable. And he's going to talk today on advancing precision and safety, mastering endoscopic submucosal dissection for esophagogastric tumors. Over to you, Dr. Parra-Blanco.
Good afternoon. Thank you very much, Sawid, for being there, for moderating, for inviting us to this webinar, and also to Creo, of course, and to everybody attending the webinar now. So my talk will be about ESD with a speedboat for esophageal and gastric lesions. It's mainly the experience I've had with my team for the last 2 months when this device was approved for upper GI work in Europe. And I don't have much data today, but I will, of course, share my experience we had and the tips, and will be, of course, open to any questions about ESD in these cases. in this location. So the agenda will cover first the challenges I believe we have in upper GI ESD, and also for people to understand why I'm working with speedboat, initially in the colorectal lesions and now in upper GI. And so I'll show one video of a gastric case of ESD with speedboat. I think it was the first case in Europe with this. And then two esophageal cases. One is squamous circumferential neoplasia, and one is Barrett's neoplasia. So, but of course, as you know well, ESD can be challenging, and there are multiple challenges, not just in the upper GI tract, but also. And some of those which I consider more important, more relevant, are the training, which is so difficult to get a proper training in ESD. There are not so many programs. Of course, we follow the ESG advice about how to do it, with how many cases in animal models, getting supervision, and so on. But we need a system that can be learned and when one can get trained in. Speedboat, I think, is a good system for that, because there's a good training system behind. So I think we need a safe technique. What makes a technique safe? Of course, first probably the operator and the team, but of course we need safe devices. We have been discussing about speedboat, which has bipolar energy, and we can discuss that later, but probably it's one of the factors which I believe may make this device maybe safer than others. We don't have any comparative studies. We have data which can be compared, but of course we need more evidence with speedboat yet. And then we know that when we can see the dissecting plane, the submucosa, is when we get into trouble. It's when trainees had to stop, and there's evidence showing this. It's when we get bleeds, and it's when we have perforation. So seeing is believing and doing things right. And also, I'll show a case about circumferential ESD in the esophagus. We know that the technique is difficult, but other indications may be more difficult for ESD in the upper GI tract, even if these are large lesions and quite impressive, but technically not so bad, because we apply tunneling technique, which is not that difficult. But the main thing is that the risk of stenosis that we know that develops in almost every case. And I'm showing the very new data, not yet published, but a very nice multi-center study led by Dr. Rodrigo de Santiago in Ramon y Cajal Hospital in Spain, mainly European. Almost every case were European, and 171 cases, and the stenosis were developed in almost 85% of them. 4% perforations. These are expert centers. There was a mortality because of a perforation with a fistula and mortality, and another one because of the steroids that they were given to the patient to prevent the stenosis. And then there was a mucormycosis, and there was a death as well. And the risk of perforation per dilatation was 0.6%. One of our patients with circumferential ESD required more than 30 dilatations. So that's something that the patient had to be consented for when we are planning a circumferential ESD. So these points I told you that I think some of the challenges we have. So I just want to show you, not to show what I have done, but just to make you understand why I'm using the speedboat, and generally speaking, the techniques I feel they are safe. So I've worked in the past in developing training. This is one of the first studies about how to use the animal models in 2010, showing that the initial part of the learning curve can be overcome by using these models. I developed with my team the clip and band technique with orthodontic bands in 2011, which now is, I'm very happy that they are being used so widely, mainly for colorectal ESD, but not only, and some modifications of these techniques. Even we thought that if energy can be the problem in causing perforations, we proved that cold ESD can be done in the esophagus and in the colon. And also we developed a new technique, modification of the previous techniques to do circumferential ESD in the esophagus, where we applied the traction not from the tunnels, but from the pillars. So these are some challenges where we've tried to work a bit on them. And we've done 6 upper GI ESD so far. 2 of them were in the stomach. I will show you, well, no complications in any of the 6 cases, no perforations, no significant bleeds. This is the first gastric case. It's a patient with a low-grade dysplasia in the anterior wall of the antrum. Of course, always imaging is a main importance because we have to first detect the lesion, then diagnose the possible depth of invasion, if it's malignant or not. So we use white light, we use neurobind imaging, near focus, and this indigo carmine. So it's a 2A lesion, but almost 2B. So we apply marking with the microwave. We inject, so that's important. It's a multimodality treatment, this platform. You have all the devices in one. Anal incision, trimming is very important so that at the end, things are not more difficult. And then we're planning to do a tunnel. So we cut the anal side. Now you can see how the rotation is important. It's very important to cut well with the speedboat to have a good tension. So nice elevation and then good tension on the tissue. And you can see how by rotating the device by our assistant, we can carry on. And I like the incision of the speedboat that it is quite deep. And that's important to prevent cutting too superficially and having a lot of bleeding. So for gastric ESD, I usually apply the clip band traction, as you can imagine. And in this case, I also thought I will use the traction after having initially done the partial tunnel. We treat the vessels nicely with the microwave. And then you can stay a bit more distant to safely cut with the lateral part of the device. So I applied the traction. And then we got the pillars and the distal end, which is done quite nicely with the speedboat. You can stay even a bit far from the target because you can rotate the device and move away from the muscle. That's the last cut. And then you see the dissection is quite nice and very close to the muscle layer. And we can treat the vessels with the microwave at the end, of course, as you can see here. And it's really safe. We have to deliver this microwave for 10 seconds usually. You can do less than that, but it's safe. And at the end, we usually apply hemostatic gel, pure stuff to prevent bleeding and hopefully promote the healing of the ulcer. So this is a gastric case. And of course, examination finishes with the stretching of the lesion and measuring. So there was a 65 millimeter lesion, more or less. So about the esophagus, done 3 circumferential ESDs and squamous neoplasia. 2 of them were considered R1, one because there was high-grade dysplasia on the edge. The other one, the patient had 2 lesions. So I decided not to cut both of them on the same day because of the risk of stenosis. Now I might have done differently, which we will discuss. And then one case on Barrett's as well that I will show you was a cancer. It was a lesion with a previous manipulation. So this is the squamous lesion in the mid-esophagus. Of course, we examine again with all these patients had a previous endoscopy for assessment, because assessment is of great importance to stage the lesions. We have a Lugol staining, I still like before ESD, although it can be debatable. We use the microwave to mark the lesion, the distal end. As I said, it's very safe and easy to apply. So we inject not too deep. We have to push and then pull back slowly. And I want to stress this as compared to the colon speedboat. I feel that you need to put a bit more of pressure. It's very important to find the submucosal space. So the initial cut was superficial. That was the muscularis mucosa. So now we find the submucosa. We see the blue color of the submucosa. And then we can stick the knife there and cut laterally. This is the distal end. We did a circumferential incision. And then, of course, whenever there's bleeding, we can use the microwave. As I say, we can use it for 10 seconds. It is very safe. And then we have to do trimming again. So to go a bit deeper in the submucosa to make the last step of the ESD easier. Now we are making the tunnel on the oral side. And again, it's good to prevent bleeding, but sometimes we are not so good and they're still bleeding. So we have to push with the cap to try and stop the bleeding and identify the bleeding site. And then with the tip of the device, we see bubbling. That means that microwave is being effective. And then there is enough evidence showing that traction should be applied for the esophagus ESD. Usually it's the clip line. I use the modified clip band line. I put the node on the band. And then we have to create good traction with creating like a stalk. So we have to find like a stalk, like a column. And then finally, with the lateral side of the device, I find the really speedboat very nice for esophagus. And that's the method I've used for the last 2 months, because of course, making a perforation in the esophagus is not nice. And I feel this is safer than most of the other knives. And we are injecting triamcinolone, 80 milligrams, very gently in the few fibers of the submucosal left, not into the muscle. And then again, using a Privastat to hopefully prevent stenosis and prevent bleeding. There's some evidence. So this is the cylinder of the lesion we took out. This is the submucosal side. And this is 6 weeks later. So I thought first that there was stenosis. The patient was almost free of symptoms. But this is a fibrin block there, but we wash it off. And it is this was my first, my best circumferential ESD, the first one I did with speedboat in terms of stenosis. The 9 previous dissections led to stenosis in all but one of them. I just dilated to 12 millimeters gently because I didn't want to push forcefully, but it was a very, very nice outcome. And then 2 other patients after 3 weeks, they haven't developed stenosis. One of the patients developed candida because they are having oral budesonide apart from the triamcinolone that I showed you. This is a very suspicious lesion on Barrett's, which in fact showed a cancer in the biopsy. I was hoping that it was the first time I saw this patient. I was hoping that EMR was fine because she had severe pulmonary fibrosis, and the anesthetist asked me to do as quickly as possible, but I thought that it was not a good technique for the patient, so we went for the ESD. Again, we have to cut deep enough, and if there's bleeding, we treat with the tip of the device. In this case, in fact, you can see I didn't put the marks because I didn't want to go very wide because of the limitation in time. The lesion was very evident. There's bleeding. You can treat the bleeding with the sides of the device as well, not just with the tip. And now we go to the oral side. This is Barrett's, but not the neoplasia. That's a regular pattern. And cutting laterally, I find quite nice and quick with the speedboat, particularly if you have a proper injection and good rotation, angulation of the knife. So, of course, the skill of the assistant is very important, and communication as well. We need to explain how we would like the knife rotated or pushed or pulled back. And we are making a pocket and then treating the vessels, and we're trying to find. See, we are coagulating with the tip, and we can even cut the vessel at the end. Just show you the distal end. And this is not a perforation. It's one of the best moments of the ESD when you find the distal end. Okay, and then I go a bit quicker. So I find the knife very nice for cutting the sides, because tunneling is easy, but cutting the pillars is not always so easy. And this knife, I place it vertically, and I find it is very efficient and again safe in cutting the lateral mucosa. Again, putting traction with a clip band line. And again, we have to try and find like a stalk, like a base, a vertical column of submucosa. And then it's when we find it safe and we complete it. In this case, we can cut laterally quite quickly. Okay. So as I said, the 3 circumferential cases, there was no dysphagia. One patient had a chest pain because of the candida. They had oral budesonide, but no stenosis, which is a very, very good result compared to only in 3 cases. It's just anecdotal, but I think that I know if it's been the combination of injection of triamcinolone budesonide and the speedboat with bipolar energy, but that's something that needs to be investigated. So what would be the advantages of a speedboat in upper GI ESD, according to what I think? So it's a multimodality platform, so you don't need to change devices. And the microwave, of course, is really nice for treating the bleeding and preventing it. We can retroflex, but we need more experience and data telling us if it works as well as in forward view or not. But so far, when I've used it, it has worked. The incision is quick, as I showed. It's user-friendly for our assistant, and it's very good for tunneling. And it's my impression that it might obviate the need for retraction in the stomach, which I use all the time, because it is a very good for tunneling. And the 2 cases I did with fibrosis, the tip managed to treat the fibrosis nicely. So about the tips, I said put enough pressure when making the incision, enough tension on the lateral sides. In the esophagus, space is limited, and we have to try and stay away from the fluid because the microwave will not work as well. And as I said, we might be able to obviate the need for traction in the stomach. So training is very important. These are 2 of the 2 training courses where I attended with Creo, and I've been very happy and honored to contribute as a trainer in some courses later on. Thank you very much.
Thank you very much, Adolfo. It's really a masterclass on use of this knife. As an early experience, as the audience, you have seen that they have shared their experience. And I will just maybe I've opened the questions, and we'll start with yourself, Adolfo. The question is to you. Have you seen any post-operative gains with regards to patients' outcome using this technology?
I mean, so far, for me, the most one is the shape, the features of the post-ESD ulcer, which I feel that with this knife, which in theory could be even criticized, with I think it happened when it was developed because the design is very different from what we had until now. It's quite wide. However, that allows you to put the device straight on the muscle because the backhand side is not going to cut. And that brings you naturally closer to the muscle, I feel, as compared to other knives. So the deeper you go, not going into the muscle, the better ulcer you will get and less bleeding because you cut the vessel from the bottom end. So that's one. But then treating the bleeding, I mean, you don't get so many complications, but you can treat the bleeding very nicely. And lastly, which for me is very important and quite impressive, is the 3 cases of circumferential ESD, which this is being sent for publication, of course, with no significant stenosis, whereas when in the 10 cases I did before, 9 of them had a severe stenosis, and 1 of them with more than 30 dilatations required. And this multi-center study from Europe showed that 85% of the patients had need for stenosis, need for dilatation, 74%. And even with mortality, which is, I think that's something very, very important. So for me, those are the main points. Probably can be quicker than other knives, but I'm still learning how to use this in the upper GI tract as compared to the other knives I've been using. So maybe I will be quicker soon.
That may be a game changer, causing less stenosis. Stenosis is universal in circumferential ESD. Do you think it's less collateral thermal damage? What is your views? Why is less stenosis with this both device?
I'm not sure. I mean, the combination of preventative measures, including triamcinolone abuse, and it's been published, and even in this paper I'm telling you, multicenter, this is a predictive risk factor for longer lasting stenosis. So even in Japan as well, they show that it may not be as good a strategy to prevent stenosis. The other one is the oral budesonide, which I used previously for 2 patients who developed stenosis. So the other factor is the bipolar energy. And of course, we know, I mean, that's why we did that study and wanted to see if a cold DSD could be done, because I was concerned that, and we know that energy is usually is monopolar. What we have available is what causes most of the important complications. And we know that touching the muscle is a risk factor for the development of stenosis. I think it's the last GI endoscopy. There's a paper showing that in the esophagus. So I'm not, we need studies. We need proper studies in animal models first, investigating that. But I'm quite prone to think that it could be one of the important factors, because we're making less damage on the muscle.
Thank you very much. We're coming to Professor Coron now. He's raised hands as well. Would you like to? You have a comment to make?
Yeah, I just wanted to make a quick comment. First, to thank Professor Parablanco, because he's not sufficiently credited on the clip and bend technique, because everybody uses that now. I use it all the time, and you're the inventor of that. And I think people don't tell this enough. First thing, coming to the Chroma platform, I see out of potential benefit on fibrosis and the nice handling of the device, 3 potential advantages. The first one is for the anesthesiologist, that we can work in patients that have pacemakers. It's compatible with pacemaker. When we work in the esophagus, it can make a big change, first thing. Second thing is for the assistant, because in my experience, when we go for a 2-3 hours ESD procedure, it's boring for the assistant. It's just after everything is prepared on the table, he or she has nothing to do. And then it becomes, with Speedboat, really a 4-hand procedure. And the assistant is involved, is key of the success. And that is for me, something important for the development. And last but not least, this has to be confirmed, but in my experience, the specimen that we send to the pathologist has clearer margins. There is less coagulation artifacts. It doesn't look like a coagulated roasted chicken, poulet grillé. It looks like a very clean specimen, and I think we need data to support this. But if we can show that we have better specimens obtained with microwave ESD, it's something that is of importance also.
Thank you very much. And another question to you is a very short answer. How was your training experience with your training journey and learning curve on this new device?
Well, it's for POEM, I felt at ease very rapidly. For ESD, it depends on the lesion, and I think the newer version of the Speedboat, the slim version, 3.2 millimeter, makes it much easier than the previous version. So I still, like Adolfo, I'm learning in complex lesions, but for most procedures, I'm very confident that it can be performed with the device that does all in one, and I think the learning curve is not so high.
And now turning to our first speaker is Dr. Alvin Esmin. You've been doing Zencas for quite some time in using, what other knives you have used before this device? And how do you compare the maneuverability and the tip control with this device?
With the previous version was hard, but I think with this one, I use a pediatric colonoscope. So the outer diameter of the colonoscope is the same, and you have a 3.2 channel, so you can move as the same as comparing with a standard endoscope. To me, the advantages of the device is that you have everything in one device, so you are prepared all the time to coagulate. And the other thing is, because of the protective hull, the dispersion of the energy when you are using the microwave, it's more in parallel than in a deep portion. So it means that the deftness of the thermal damage is not so high. So when you try to apply a lot of times microwave I'm not telling about cutting, because if you cut with the tip, you cut everything. So it is you can perforate with the device when you are in front of any kind of tissue. But when you are trying to coagulate over the muscle, it's really safe. It's really difficult to perforate the muscle with this ability. And when you go with standard current and standard graspers, sometimes you have some troubles. So to me, this way also this is one important feature of safety of the device.
Thank you very much. The last question may I ask to Adolfo is the one: do you have any experience when you retroflex a scope in the upper stomach? Do you think it's a maneuverability and the precision of this knife stays as it is in the forward viewing?
Yes, I've used in the upper body lesser curvature. It retroflex well. I think the needle, I felt that it may be good to have the needle almost pushed, not completely open, but slightly pushed, so that you can retroflex and then advance the needle. Because if you have to push the needle when the scope is completely retroflexed, it may be more difficult. The same as would happen with other devices, but it works not only in the upper GI, also in the rectum. For instance, the case we were doing today, we were retroflexing in the lower rectum with the speedboat, and particularly, of course, with the 3.2 device, it can be done. Yes, and microwave, inject, and cut and dissect. Yes.
Fantastic. And he said, last is the one, the Creo team, that if anyone showed any interest, perhaps we could leave a contact number they can get back to you. I mean, I've seen a lot of experienced endoscopists as a participant in this seminar, and they might be able to be in touch. And thank you very much. What a real delight it was to have three experts talking their early experience with advancing treatment strategies, managing upper GI diseases with this advanced energy platform. And thank you very much. And thank you for the audience, and have a lovely evening. Bye-bye.
Thank you to everybody.
Thank you. Bye-bye.
Bye.